So the sorts of methods that I'll be discussing take as their aim adjusting per person predicted cost based on diagnostic and demographic inputs, risk indicators. Typically, these will come from claims or other administrative data. And I want to be clear, when I use the term predicted cost, I'm referring to an estimate of expected cost, which would be the output of a fitted model. So this could be concurrent or prospective vis-a-vis the diagnostic input. So we could be talking about predicting next year's per person cost from this year's diagnosis, or predicting, if you will, what this year's current costs, or this year's cost should be given diagnosis, if you will, or what they would be expected to be. And so the sort of typical examples of this, where this sort of methodology is used, are predicting health claim costs, summing predicted costs across members, or assessing a provider performance by comparing the sum of predicted versus observed costs with a healthcare provider's caseload. Now, diagnoses on healthcare claims are recorded in ICD-9 CM codes. There are over 13,000. And so generally any sort of risk adjustment procedure that involves these diagnostic codes, it begins with grouping them or sorting them into a manageable number of mutually exclusive diagnostic groups. And so these grouping schemes, sometimes referred to as groupers, aim to assign each diagnosis to one and only one group, end up with a manageable number of groups, and optimize within group consistency with respect to clinical features that might tend to predict healthcare utilization. So what organ system of the body is involved, the severity of the condition, chronicity or persistence, complexity, and so forth. Now, so as examples, these are three risk adjustment systems in the left-hand column that are well known. Well, the first two are quite well known, generally to health services researchers, and the last one is sort of more recent. And each of these begins at its first stage with a grouping scheme. And so in the center column, I've listed the name of the grouping scheme associated with that system, and the number of diagnostic groups that the ICD-9 codes are sorted into. And it's sort of interesting. You can see that over time, the first was developed in the late 80s, and then in the late 90s, and then in this last decade, the number of diagnostic categories that are used for grouping have grown because, of course, ability to handle sort of the complexity and size of data sets has grown, so people have been more comfortable with a larger number of diagnostic categories. And I will be referring back to these risk adjustment systems. That's partly why I provided references from them, because these happen to be ones that are described in peer-reviewed published literature, so one can really understand how they were constructed. These, I'm going to be talking about these risk adjustment systems, adjusted clinical groups, diagnostic cost group, hierarchical condition category, and clinical risk groups. An alternative grouping scheme, those were all proprietary, although they were originally developed in academic settings. They're proprietary systems or models, if you will. But an alternative grouping scheme, not a formal risk adjustment system, but grouping scheme that is in the public domain is the clinical classification software, which maps ICD-9 CM codes into 260 diagnosis categories. It's actually more now. It was 260 when they did this research. It is updated and revised every year. It's part of the Healthcare Cost and Utilization Project, which is sponsored by the Agency for Healthcare Research and Quality at the U.S. Department of Health and Human Services. And the reason I'm presenting this is I'm going to be using this later as a sort of as part of a more hopefully transparent risk adjustment process. Now, it's relatively straightforward to group diagnoses. One generally would, health services researchers and physicians are involved in assigning diagnoses based on various clinical criteria to one or another group. And so the development of grouping schemes is generally fairly empirical and straightforward. The complexity arises, of course, in that patients can have, in a given time interval or at a given point in time, and typically do, have diagnoses in more than one of these groups. And so one has to think about interactions between diagnoses and between diagnostic groups in terms of their effects on cost. One can sort of generally think of these interactions as either positive or negative. The positive interaction would occur when two diagnoses cost more when treated together in the same individual than separately in two. And so, examples that come to mind are when a second disease process complicates the first, rendering a much more severe condition. So, for example, a patient with chronic obstructive pulmonary disease might develop an upper respiratory infection that would be an inconvenience to a healthy individual, but might land that person in an ICU. Negative interactions will occur when two diagnoses cost less together in one patient than separately in two. This often occurs when two procedures or tests can be managed, when one procedure or test can be used to treat or manage one condition. So the two diagnoses are managed with the same set of services. Now, of course, the number of potential interactions is vast that one has to consider, and our aim really is to identify those that are consequential, that have important effects on costs, and to incorporate them into a prediction model. And so to think about the complexity of this task, one can consider of the grouping schemes that I showed you, the one with the fewest diagnostic groups were the aggregated diagnosis groups of the ACG system. There were 32 of them. We could restrict attention to interactions involving, that should say, fewer than 6 diagnostic groups. It says more. We could restrict attention to it says ignore interactions involving more than 6 diagnostic groups. So we restrict attention to the 6-way and fewer-way interactions, if you will. And even so, we still have potentially over a million interactions to consider for it. A procedure that involves selecting interactions one at a time, for example, by starting with a main effects model and then adding 2-way interactions and 3-way interactions using sort of a stepwise linear regression modeling approach is obviously infeasible. As you'll see later, these combinations of more than 6 diagnostic groups are not at all uncommon. Specifically, if you're looking at, say, a window of time, like a year, for example. So a couple of alternative approaches, or two, I'm going to sort of generalize approaches into two categories, and one I'll call deterministic modeling, and the other algorithmic modeling. And what I'm referring to as deterministic modeling, this is the typical approach that has been taken. And it involves essentially anticipating the magnitude and direction of every potential interaction among diagnostic groups using clinical reasoning and historical data analysis, and then incorporating those assumptions into a deterministic model of interactions.